Okay. I think people will still be coming in, but I'll get us started. Welcome and good afternoon. I'm Marianne Mason. I'm an associate professor of emergency medicine and associate director of the Buehler Center for Health Policy and Economics here at Feinberg School of Medicine at Northwestern University. And I'm so very pleased today to have with us Dr. Lauren McGee, who is a researcher at Indiana University School of Medicine, to talk with us about non-fatal firearm injuries and community-led interventions to prevent them and mitigate the damage of them. So this, as I mentioned before, this is a co-sponsored talk, co-sponsored by the Buehler Center for Health Policy and Economics. And I want to urge people, if you haven't joined our center, please do. We co-sponsor many talks, and this is, I think, a very interesting talk that probably wouldn't be sponsored by other centers. So we have a unique niche here. So I want to, as we get going, remind everyone, we'll take questions in the Q&A section of the Zoom. So we won't be monitoring the chat, but we will be taking questions in the Q&A. And we're going to hold those to the end of Dr. McGee's talk. So without further ado, I want to introduce Dr. McGee. She is an assistant professor in the Department of Pediatrics. And she also works in Children's Health Services research at Indiana University School of Medicine. She occupies a very unique space in our academic institution. She is a criminologist and a health services researcher, and she does interdisciplinary research and has an agenda focused on preventing firearm injuries, reducing health disparities within communities, and working with communities to identify opportunities for intervention among people who are impacted by firearm violence. She currently leads two projects funded by NIH focused on examining direct and indirect trauma among children, youth, and families who are exposed to firearm violence. Dr. McGee received the Multidisciplinary Science Award at the National Research Conference for the Prevention of Firearm-Related Harms in 2023 and is an up-and-coming researcher in firearm violence prevention. So please join me in welcoming her for her talk this afternoon. Dr. McGee?
Thank you very much for that very nice introduction. It's nice to virtually see everyone today. This is the first Zoom presentation I've given in a while. I'm very grateful to be here and thankful for the invitation. So I will be spending today talking about some of my work, primarily focused on non-fatal firearm injuries, and then specifically into one of the community-led interventions. So disclosures, I do have NIH support currently, and I'm an unpaid board member for the Hoosiers Concerned Against Gun Violence. So today, I'm just going to kind of go over my overall approach. As Dr. Mason said, I have a unique background, kind of some of the formative work I've done in this space, mental health outcomes of survivors of gun violence, as well as the family impact, and then go more in depth into one of the community-led interventions that I've worked on. I do want to start by acknowledging that I am not a survivor of gun violence myself, but from personal experience, I know how indirect exposure can really impact the family. So as in my intro you heard, I have a unique background, and I want to share kind of my story of how I got involved and interested in firearm injuries. So the impact of violence, firearm injuries, I've really been working in this space for about 18 years now. It started when I was a research assistant and analyst in the cold case homicide unit in Indianapolis, going through old cold case files, looking for modern DNA evidence. And it was through that work that I really saw the impact that violence has on families, even decades later, the family members that were still calling the detective on the year anniversary of their loved one that they had lost 25 years ago. And from that role, I moved into a role as a crime analyst, mostly working with homicide data, and had noticed that many of the homicide victims had been previously shot and survived. but we didn't have any data at the point, this is about 15 years ago, on non-fatal injuries. We couldn't tell you how many people had been shot, and we definitely weren't, from a police department perspective, thinking about that non-fatal injury point as a point of intervention. So that's really where I got my interest in kind of the public health approach. So again, my training gives me a unique perspective. I'm trained as a criminologist and health services researcher, and really understand the problem from a public health perspective, but also from a crime and law enforcement perspective, even though we should not just think about it as a crime or law enforcement problem, but that we really need to move more upstream when we think about the prevention of firearm injuries. So that interdisciplinary training and work, I've been able to partner with these different disciplines, as you can see from the Venn diagram, the police and justice system, the medical system, public health, and the community. And firearm prevention really sits in the middle of each of these different disciplines. This gives me a unique lens too for really any health problem. You could change out firearm injury prevention with overdose or mental health, homelessness, and all these fields typically touch these more public health problems. And I would be remiss if I didn't first acknowledge my community partnerships that have really made this work possible over the last 18 years, specifically the last 5 years. And community partnerships is vital to the work that I do and why my work is so focused on Indianapolis, but it's also vital to being able to ensure that we have access to secondary data, that we're able to make sure that our interventions and research is culturally competent, and the ability to adapt the interventions that we need to for the right population. I partner with the police, community groups, trauma surgeons, psychologists, pediatricians. I sit in the Department of Pediatrics because firearm injury really touches each of these different disciplines, and we need these multidisciplinary teams and approaches to address firearm injuries and violence. I've also had amazing academic mentors and collaborators that have made this work possible. But it's through these unique partnerships that I've built. You can see we have our Deputy Chief of Investigations for the Indianapolis Police Department. These are our community advocates that I will talk about this intervention. Also community advocates presenting to our city county council. Some of my very close community collaborators that have been on research projects and publications with me, and then our different clinical systems that I also work with. And it's through these partnerships that I've been able to create and develop the Bridge Initiative, where our mission is really to make these system level changes within the justice and clinical systems to help families and children develop the capacity to recover from the trauma of firearm injury. So this is really kind of the purpose of my research, how I approach research over the last 5 years. The overall goal being to reduce firearm injuries, improve health equity of people and communities impacted by firearm violence, with the focus specifically being on firearm injury exposure and health outcomes among those children and families. A lot of the work I'll talk about today is more from the epidemiology. Again, who are the people who were shot and who have survived? What are their health outcomes? Moved more into the intervention space in the last few years. And then all of my work, it's extremely important to make sure that these findings are being translated back into the community to make real change. So as most people in the audience know, firearm injuries are a public health problem in the US. It's not something I necessarily need to tell this audience, but I want to make sure that we're at least on the same page language-wise with the type of firearm violence we'll be discussing today. So there's really kind of 4 main types of firearm violence. Mass shootings, which could fall mostly in homicides, that we hear the most about. News media usually picks these up always because they're high profile, but they're really the least frequent. Our unintentional, which is the bottom line, is typically when a child gets a hold of a firearm and unintentionally shoots themselves or a family member or a friend. Suicides are the highest rate of firearm deaths. Self-harm, and then homicides are in the middle and have started to go down, but that's our intentional assaults or purposeful community violence as we think about it, and make up about half of all non-fatal shootings as well. Each different root causes and interventions are needed to prevent these, but the common mechanism being the firearm. So my research really focuses on homicide or the intentional assaults, community firearm violence, as we'll talk about today. And community firearm violence is a multifaceted issue with many different drivers. The social determinants of health framework really helps encompass most of the common root causes: poverty, the social and community context, the cultural, which means the cultural norms within a neighborhood regarding guns, violence, the police, the physical environment of a neighborhood, such as the abandoned homes, broken lights, cracked sidewalks, trash, graffiti, and then disparities in access to healthcare and quality of education. My work and what I'll largely focus on today is talking about the social and community context, neighborhood environment, and then health outcomes, specifically related to health care access. And so as of 2017, and this graph stops in 2020, unfortunately, this trend has continued, that firearms are the leading cause of death among children and young people in the United States, surpassing motor vehicle crashes. But beyond firearm deaths, we know much less about non-fatal firearm injuries. So those are the people who were shot but survive. But for every firearm death, there's an estimated 2 to 3 non-fatal firearm injuries. And firearm violence or non-fatal firearm survivors often suffer physical disabilities due to their injury. But there's also the sociological, the psychological, and the emotional effects due to the trauma of their shooting. Many survivors of community gun violence return to the same neighborhoods that they were shot, and many of the same neighborhoods that their shooter often still lives in. And unhealed trauma can lead to poor health outcomes, higher social costs, higher healthcare costs, and can really continue that cycle of violence, leading to more shootings and even more trauma. And it's that cycle of violence that my work is really trying to break. Oh, hold on. PowerPoint just decided to freeze up for a second. Okay, well, I can talk about the next slide while that is going. And so we know from research that I've done and that others have done that firearm injuries are associated with higher rates of depression, anxiety, and PTSD for the survivor themselves. So that's the direct survivor who's been shot, as well as people who live in communities with higher rates of gun violence have higher needs when it comes to mental health after a firearm violence exposure. For instance, children that have lived within 2 blocks of a shooting have higher needs for mental health in the emergency department following that period. And then also this is expanded some into children and siblings of people who have been shot but survived, and some I'll talk about today. That it's the direct survivor that has higher needs, mental health needs following a shooting, people who live in communities, as well as the siblings. But we know much less about the best opportunities for connection to care and how these firearm injuries have the long-term impact in health of family members and communities. And so since I'm in Indianapolis and most of this work that I'm going to talk about is in Indianapolis, I want to discuss kind of the overall prevalence of gun violence in our city. I have Chicago on there as well for non-fatal shootings, so we can see the kind of comparison for the rate per 100,000. So the bottom line is our Indianapolis homicide rate per 100,000. We are historically above the national average. And then our rate for non-fatal shootings over the last 9 or so years. And we are lower than Chicago. We've had years where we do actually have a rate that has been higher than Chicago. And our non-fatal shootings do occur 3 to 4 times more often than our homicides. And we have started to see kind of a decrease as many other large cities have. And the data that you're seeing here from the police department, and the police department is where most of the local data comes from, and for a reason I'm going to talk about. So from a firearm injury data standpoint, so non-fatal firearm injuries, there is no national comprehensive data set on non-fatal shootings that exist. They exist for deaths, but not for non-fatal firearm injuries. The national systems that do exist do not have a complete comprehensive picture of it. So the kind of de facto national system that we have used from an academic standpoint over the last few years has been the Gun Violence Archive, which is a nonprofit and largely compiled from media reports. There is a new one that every town has just published called Every Shot. I'm less familiar with this, but they're trying as well to make sure that non-fatal firearm injury data are available to people in real time. Some of the work that my team has done is comparing official police records to media reports or the gun violence archive to compare to see what the accuracy is of that kind of de facto national data set. And what we've found is that the media actually only reports about 40% of non-fatal firearm injuries. So despite seeing it on the news on a daily basis, at least here locally in Indianapolis, they're only reporting about 40% of non-fatal injuries. So for every 2 out of 5 shootings that are reported to the media, and the media are biased in who they report shootings on. Child victims, female victims, as well as shootings that involve multiple victims are more likely to be reported. And this is problematic if we're thinking about it from either an epidemiology standpoint, informing interventions or evaluating interventions. But if we're using bad data or biased data, it's just going to bias our overall results. And at the local level, firearm data injury exists, but it exists in silos largely. The EMS, if I'm a shooting victim, EMS might have a record of mine. The clinical system has a record of my shooting. The police has a record of my shooting. I may or may not make it into the trauma registry data, but each of these systems in and of itself are incomplete or use their own different definitions of intent, or if they even make it in. For example, not all non-fatal shooting victims are transported to the hospital by EMS. Some victims drive themselves to the hospital and just walk in. The trauma registry data, there has to be a certain injury severity level to make it into the trauma registry. So if you were just shot in the leg and released, you don't necessarily always make it into the trauma registry data. So this is where my work has really relied on these local data partnerships and the ability to better understand kind of the overall true prevalence of non-fatal shootings by linking these different data systems together. So can we understand the true prevalence of non-fatal injuries by linking police data with other systems? And the short answer is yes. So in Indiana, police have a mandatory, or clinical systems have a mandatory report to law enforcement anytime they treat a firearm injury. Therefore, we know that the police are mostly, we can assume at least probably like 99% being called for all non-fatal injuries and have done the work to kind of confirm this as currently the best data source locally. So the work, and for my team, we've linked clinical data, Medicaid data, birth certificate data, police data, trauma registry data, using different deterministic and probabilistic matching algorithms, using the name, date of birth, social security number at the individual level over about a 20-year span. So we're able to follow an individual longitudinally, but also take that shooting incident and look at how that specific shooting was coded in each of these different systems. So for instance, we did a study where we looked at a victim's case in the police record as well as the clinical record within a 24-hour period to see if they were in both systems. And overall, we did find about 65% overlap between the police data and clinical data. There were another 20% of assault-related shootings that did not have any sort of firearm code from an ICD coding standpoint in the clinical data. So if we were just going to take the clinical data and the ICD codes and say we need all the assault firearm-related injuries, we can say that we'd be missing about 20% of the injuries that were even in the clinical system. And then there was another subset of about 10% of injuries that never even made it into the clinical system because they did not seek medical care, but they were in the police records. The other piece that the police data are able to add that clinical data don't have is the intent. Other national studies have shown that clinical data, the intent in the ICD codes is unreliable, but the police always have to investigate to figure out if it was a criminal intent, self-harm, or accidental. So their intent is more accurate, as well as the motivation around the shooting. We've done a similar linkage with the police and trauma registry data for all the trauma centers in Indianapolis. We have 4, one being a pediatric, and the results were very similar to using EHR data. And so this linked data, one, gives us the comprehensive picture of non-fatal firearm injuries, but it also allows us to ask different questions and understand different outcomes from a justice standpoint as well as health-related outcomes. And so using these linked data, because we don't know a lot about the health of people who have survived a firearm injury, we know more in the last few years than we ever have, but we still trying to understand, are they accessing the healthcare system? What are their needs following their shooting? So using these linked data, again, the police and clinical data to look at clinical care utilization and mental health outcomes in the 24 months before someone was shot and then after they were shot, we were able to see that the most prevalent diagnoses were for depression, anxiety, stress disorders. They all increased following the injury, as we would expect. There were differences in age and race. Survivors younger than 14 were more likely to receive mental health care. And the 15 to 19 were less likely, which is the group that we know is at elevated risk to be involved in gun violence. And then survivors who identify as Black were less likely to receive mental health care compared to white survivors. And then overall, we know from prior research that we expect survivors to have higher mental health needs, but over 70% of the survivors weren't connected to any sort of mental health or substance use care following their injury. So we really wanted to understand more of how survivors were adjusting or emotionally healing after their injuries. So we did qualitative interviews. I partnered with my long-term community partners now, Anthony and Beatrice Beverly, to interview survivors of non-fatal shootings. We interviewed 18 survivors between the ages of 15 and 50. Most had been shot within the last 5 years. There were 3 that had been shot as many as 20 years ago. And we asked about their lives since they were injured, how they emotionally healed from their injury, barriers and facilitators to connecting with mental health providers. And we really heard kind of 4 main themes. These are quotes from the survivors themselves. And the 4 main themes that emerged and what survivors were telling us is that, one, they were saying they didn't need help, that they were fine. The shooting didn't impact them at all, and it was just kind of normalized of gun violence, despite describing every criteria down a PTSD screener or depression or anxiety screener. They described an unwillingness to talk about their shooting. They felt like they couldn't talk about their shooting, or they were fearful that they were going to get in trouble. They connected the code of the street, which code of the street is a mindset of you don't talk, you don't say what happened, you don't snitch. Typically, more applied with the police, that you don't talk to the police, you don't tell them what happened. The mindset also was connected with medical providers or therapists. You don't talk to them. You can see that in the quote in the bottom left corner, because that could be viewed as snitching. Of the survivors who did seek treatment, they didn't feel like they could connect with the provider, that the provider that they had connected with didn't understand their life, didn't understand their communities, didn't understand the different complexity of moving through their communities as a gun violence survivor. So they really wanted to have more of that credible messenger of a survivor or a mental health provider who, one, identified with them, but then also really kind of understood the complexity and moving through their community and what they've been through. And the other piece that they mentioned was the impact on their families. And this piece was not necessarily something we asked about, but something that each of the survivors, despite talking about how their shooting didn't impact them and they were fine, but how their shooting really had an impact on their family. And they were overwhelmingly worried more about how the impact, how the family was impacted than it was on themselves. And then the last piece, which we didn't even ask about, was that the survivors, over half, said that the interview experience was the first time that anyone had asked them about their shooting. And that even though we were just conducting research, that it felt good and it felt like therapy to them to be able to share their story in a confidential space, where they weren't fearful that they were going to get in trouble. So that piece was really kind of touching for all of us that did the interviews, hearing that. We've since done a subset analyses of these interviews based on the responses about our hospital-based violence intervention program in Indianapolis. We did not specifically ask about those, but many of the survivors discussed that. And really, the two other main themes that came out from that analysis was that they were unaware of the hospital-based violence intervention program resources. Our program here is called Prescription for Hope, and they thought it was like someone that was going to help them with their prescriptions or something completely not related to the services that were offered. They also discussed that they didn't want to change at that moment in time or enter into a role in the program at the time of their shooting, but that there was a need for follow-up after they left the hospital, which has been changed for our current program. But it was really from these interviews, the impact and the emotional healing that survivors went through with their families, that was really intrigued me and I wanted to learn more about. So these are two of the quotes about the impact of their families that really has stuck with me, and it really informed kind of the current work that I'm doing today. Because we talk a lot about this ripple effect of firearm injuries or the impact of communities and the impact of family members. We don't really know or have a great understanding of what that really means or looks like. So we went back to the secondary linked data. Part of that linked data with the police records are Medicaid claims data for the state of Indiana. So we started with, again, defining our non-fatal shooting survivors from police records, linking them to the Medicaid claims data. And then within the Medicaid claims data, there is a family case number. So anyone that's on that Medicaid kind of insurance plan, you're able to identify as a family member. So we define the family members and then retain the non-family member Medicaid covered population to be able to compare prevalence rates. We looked at their mental health outcomes in the year before and after the injury for both the direct survivor, so the person who was shot, and then their family members as identified in the Medicaid data. And what we found was that youth family members, so the siblings and children of non-fatal shooting survivors, saw about a 3% increase in mental health prevalence in the year following the shooting of their loved one compared to the year prior. Family members saw increases across stress, anxiety, depression, mood disorders, as well as disruptive behavior disorders. And then so among survivors with a new mental health diagnosis being that they had no prior mental health diagnoses before the shooting, that they had one after the year following the shooting, the majority were the youth family members compared to adults or direct survivors. And we did see an increase in mental health utilization, but it was a much smaller proportion of mental health claims compared to the overall healthcare utilization in that post-injury period, which really might indicate that there are those potential barriers to care, which are likely explained by what we heard in the qualitative interviews. Competing interests, such as they need to take care of their basic needs, housing, other social needs that they have to take care of beyond seeking mental health care, disparities in resources at the time of the injury. So for instance, again, we have 4 level 1 trauma centers here in Indianapolis. One has had a hospital-based violence intervention program for a long time. One just started in the prior year. And then the other 2 don't have anything or any standardized resources for non-fatal shooting victims. And so although the overall mental health prevalence was low in the about 3% is fairly low, it gives us an indication that children and siblings of survivors are impacted. And this is, again, really where my work is sitting today to better understand. So just kind of to summarize this kind of formative work that's really informed the current intervention that I'm going to talk about next and some of the future work that I'm doing. on families, having to better identify family members, and looking at the social networks of family members and health outcomes. We can really see from these findings where the criminology and public health and medicine really all come together, if we think back to that Venn diagram. So from this research, we now know that youth exposure is just as harmful as being a direct victim. And this is obviously problematic for a number of reasons, as most current interventions are focused on adults or focused on the youth who have actually been shot or been arrested for a firearm charge. We have the need for this integrated data, one, to just identify who's actually our shooting victims, but also to inform interventions, evaluate interventions. And it really needs to be done at the local level and ideally available to communities through some sort of data dashboard for them to use and inform their own work. That there's differences in youth survivors. So indirect exposure may have implications for the future involvement in violence, and just confirm the work that we really need those credible messengers when we think about the emotional healing and mental health care of survivors of non-fatal shootings. So it's not as simply as just improving access to healthcare, that we need to make sure it's the right connection to care that survivors of gun violence are getting. And so this formative work really kind of informed and helped design the implementation of a non-fatal community advocate and support program within our Indianapolis Police Department. So most police departments in the US have some sort of victims advocates or victim services that have typically reached out to family members of homicide victims, sexual assault victims, domestic violence, a different array. Most do not reach out to non-fatal shooting survivors. So the overall project goals of this program was to implement a trauma-informed care model into the police department to provide resources for non-fatal shooting survivors and family members, again, which is not standard of care, at least it has not been standard of care in Indianapolis. To one, increase the connection to services. So can we connect survivors of gun violence to services in the same way that an HVIP does, but from within a police department? Reduce future firearm injuries and improve case clearances for non-fatal shootings. Non-fatal shooting clearance rates, so clearance rates being if someone's arrested for that shooting, are extremely low. They hover around 20% as a national average. So can this program help improve clearance rates? The program was really kind of designed with Deputy Chief Adams, who's still the current Deputy Chief of Investigations in Indianapolis, really saw the importance of non-fatal shootings, of not just focusing on homicides, but we have to address non-fatal shootings as well if we're going to prevent future homicides. Advocate and mom, Deandra Dykes, who's been a national advocate for resources for non-fatal shootings. Her son was shot about 12 years ago and lives the journey of survival every day. And then because I've been a research partner and kind of in the space of this work, brought in as a research partner. So the advocates, there's 3 community advocates. The program process is really when someone is shot, the police department responds, the detective takes the initial case, and then the advocates, we've got 3 advocates, all have personal history with gun violence or have lost a family member to gun violence, that they outreach. So they call every shooting victim, every non-fatal shooting victim that IMPD covers, which is 95% of Indianapolis. That's about 500 non-fatal shooting victims a year. They call them within 24 hours. If they can't connect with them, then they send a letter to the address that they have on file. And then they also try to follow up with victims and or family members in the week following, the month following, or as often as the survivor or family member has asked for. So this was a pilot project from June of 2022 through December of 2024. The project has recently been funded for another 3 years through the Bureau of Justice Assistance. And during this time, we collected data on how many victims the advocates were outreaching, how many victims or families did the advocate actually connect with or talk with on the phone, What was the follow-up rate? How many victims did they follow up with? What type of services were requested? From social determinants of health, housing was a big one, food, job training, emotional support, victims' compensation. The advocate would walk the victim or the family through the victim compensation kind of application process. And then as well as the advocate is able to connect the victim back with their detective or give them their detective contact information to better understand or participate in their investigation. We looked at the re-injury rates, so how many of the victims that went through the program were re-injured or shot again in a different shooting. And then we also looked at the case clearance rates. So did the case clearance rates go up following this program using difference in difference modeling? And so through that June 2022 through December of 2024, some of our descriptive findings is that the advocates were able to outreach the majority of our non-fatal shooting victims. We had 82% of victims. They did outreach some of our shooting or stabbing or assault, hand, fist, feet assault victims as well. The majority of the victims identify as Black, majority are male, almost 2,000 victims. They were able to outreach 75% of our overall victims. The 25% that they did not outreach, so did not make that initial phone call in a 48-hour period, were either due to not having a phone number. Lack of phone numbers was a really big barrier to connection with the victims, or the detective asked the advocates not to reach out to them. And the reasons behind that was either there was still something in the investigation that they didn't want the advocate to reach out for, or the victim was also considered a suspect in another case. So of the 75%, so the 1,200 victims that they connected with or outreach, they were able to connect with 45% of a survivor or a family member. Which is a fairly decent connection rate considering that they have been discharged from the hospital, and this is through a phone call within 48 hours. They talked to a family member when either the survivor was under the age of 18 or the injuries were so severe that they weren't able to talk to the victim. And then of the victims that the advocates outreached and connected with, there were about 3.7 that were re-injured in a subsequent non-fatal shooting, which is a little bit higher than our pre-injury interventions. This is still an outcome we need to better understand. And so the services or the resources that were provided the most requested, the dark blue line on the left is that initial contact. So when the advocate initially connected with the victim, the light blue line is on a follow-up. They weren't able to follow up with every victim that they had initial contact with, but emotional support was the highest kind of request from the victims. And emotional support could be connecting with a counselor or a therapist or a mental health provider, or just getting emotional support calls from the advocate. Many of the survivors just kind of anecdotally told the advocates like, wow, it's nice that somebody called and is just asking how I'm doing. Social determinants of health, again, housing, food, job training, utility support. They were able to provide financial support if the survivor couldn't work following their shooting, to help pay any sort of utility bills. Walk them through victims' compensation, and then reconnect them back with their detective. We also interviewed, or I interviewed all of the aggravated assault detectives to kind of learn what they thought about the program and the need for the program. If anyone's worked with police departments before, any sort of change or new program, always there's a little bit of hesitancy towards accepting something new. So we asked the detectives kind of just overall about the program, what they understood about the program, and really saw these kind of main themes that The detectives saw the advocates that are important. They knew they needed services for the victims and the families. They thought it was helpful to have a non-police contact to help, and not that they helped in the investigation, but that they were able to point them to someone else that was a little bit softer and not a police officer. There was a lot of kind of lack of understanding and communication about the program as it was implemented into the department, confusion about what the advocates do every day. The advocates work during the day, all the detectives work late shift or night shift. So they didn't really see each other. So just kind of that unknown piece made the detectives just kind of even more unsure about what was happening. And they weren't informed why the advocates were chosen, that they were chosen because of their lived experience and their ability to better connect with the victims. So it was kind of viewed at times as being on different teams with different goals. And then we also asked the detectives about their thoughts on the clearance rates. Like, do you think this program is helping with the clearance rates? And the detectives really kind of had mixed thoughts on this. They didn't have any concrete examples that could say, yes, this has helped. Therefore, they weren't really willing to say much beyond. They thought any victim that was going to cooperate or help in the investigation was going to do it within the first 48 hours, irrelevant of anything else that was going on. And then this concept of bought cooperation came up that they thought could be problems later in court. This was a new concept to many of us, and we've had a few conversations with people across the country and police leadership since this, and the idea of bought cooperation being that, like, if the police department is providing utility support for a victim, that it's going to cause complications in the court later on if this case goes to trial. That seems to be kind of more of an urban myth at this point, but more work to do there. And then if we get to the difference in difference modelings and the case clearance piece, and the case clearance piece is so important to this because to really get buy-in from a program within a police departments are evaluated on their case clearance. So if we can show this program's improving case clearance for non-fatal shootings, it's a much stronger buy-in to keep this program implemented and continuing. So we saw the green is non-fatal shootings before, non-fatal shootings after, and then we used homicides as a comparison group. We also looked at armed robberies as a comparison group. That just seemed like a different, it was just too different from non-fatal shootings or homicides. So we can see here just from the basic descriptives, these were run by Dr. Alberto Ortega at IU Bloomington, and Dr. Parker from Northwestern was on this as well, that there was some increase. And then if we look at the model here, when we controlled for victim demographics, beat, so where the shooting actually occurred, the detective working the case could definitely have an impact. And then the month and year as fixed effects, we can see there's almost an 8% effect that this program had on improving non-fatal shooting clearance rates. And then just some key takeaways and future directions to finish up before I take questions. So some key takeaways and challenges from this program specifically is that survivor outreach or victim outreach for non-fatal shootings from within a community or police department is feasible. It doesn't have to take place in a clinical setting. The lack of available phone numbers in association with the police were some of the very biggest barriers advocates were hung up on as soon as they heard that they were at all associated with the police department. We are working on actively more training and communication between the advocates and the detectives. And then we have this indication that the program does improve clearance rates. So we want to do qualitative interviews with survivors and advocates. We just didn't do that in the first pilot piece of it. Explore more of a text digital component of it. Can we connect with survivors through text messages? To kind of facilitate more of that follow-up, but also to prevent some of the trauma that the advocates go through, that they've all experienced and lost loved ones to gun violence, that they kind of relive their own trauma every day doing this work. Examine more of the longitudinal outcomes, re-injury rates, arrest rates, connection to services, further explore this causal mechanism of the program and role of cooperation, which we're looking at funding for specific projects. And then the overall project has 3 more years of funding through the Bureau of Justice Assistance to fund the advocates, but then also try to create more coordinations of services across the clinical and community groups along with the police advocates. So how do we better connect with the HFIPs within Indianapolis, as well as the community groups that are really kind of doing this work? With that, thank you.
Well, thank you so much, Dr. McGee. We do have some questions.
Awesome.
The first two are possibly more related to the data you're working with. And the first one is from Joe Feinglass, and he's interested in what your thoughts are on how good hospital e-coding is for intentional assault, using e-codes. How accurate is that?
Yeah, so not as accurate as we would hope, or as accurate as at least I thought clinical data would be when I came from working with just police data. So we know from studies that have been done in other healthcare settings around the country that the intent is non-reliable. And then that study that I did talk about, that specifically the E-codes for intentional assaults were not reliable. We found 20% that had no E-code at all, but were classified as assaults in the police data. So I would be curious to do it now with more updated ICD-10 codes. This is using ICD-9 and ICD-10, but it's not reliable. And from the conversations I've had with clinicians, their mindset is, it doesn't matter to us. We're treating the patient, irrelevant of the intent of the injury.
Yeah, so there's almost not a clinical
Right.
motivation to record that. Okay.
Right, which is where that, yeah, strong suit comes from, the police linking with the police data, because the police have to understand the intent.
Right. So the importance of multiple sources and entities involved. Great. And then this may go back to that slide you had on clearance rate, where you showed, I believe, an improvement in clearance rates.
Yeah.
Joe again here wonders what the overall Indianapolis clearance rate is for non-fatal shootings, and is there much variation in that nationally?
Yeah, so the Indianapolis clearance rate, we've averaged about 26% the last year or two for non-fatal shootings. And then the national clearance rate that I've seen from most police departments hovers around 19-20% for non-fatal shootings. Whereas homicides, it's typically more up around 50-60%. I have heard of cities, I think it was Denver, Colorado, clearance rates as high as 50% for non-fatal shootings, but most are around that 20%, and we have about 26%.
Okay, and then regionally, in the area, is Indianapolis very much from the surrounding counties? Do you know?
I actually don't know.
Okay.
No.
Okay, great. I'd like to sneak in a question, and then we have one more,
Okay.
which is something that stood out for me is you talked about a possible increase in re-injury rate. And I'm just wondering what your thoughts are on that. It seems counterintuitive to me.
It is counterintuitive, and you probably heard my pause because I'm not sure if I know what to fully make of that yet. Our re-injury rate overall is typically around 4 to 5%, so it is lower than our overall average, but I think we would need to get more into the nuances of if those victims are actually connecting with the services of the resources they've been provided. Because right now we can only know that the advocate has provided the resources, not that the survivor has actually acted on and connected with a mental health provider or um, used the service that was given, if that makes sense.
Yeah, I think
So
it
yeah,
does.
yeah. So more to come, and would love to talk more about that because yeah, it is
I just
counterintuitive.
also was thinking, do you actually just have better re-injury rate measurement because the
Right.
amount of contact you have with the victims?
Yeah, that would be a great idea beyond just another shooting. Absolutely.
Okay. We have one more question in the Q&A. So if others have questions to send in, you should do it now. But this is an interesting question. Thank you for your presentation. Very interesting and important series of studies. This person would like to learn more about the advocates involved, including maybe details on how they were selected, trained, and compensated. Were they already serving in a similar capacity or involved in some way prior to joining the study? And then finally, what are your thoughts about sustaining a program like this long term?
Yeah, great questions. So the advocates were selected. As I mentioned, Deandra Dykes was really the leader in this space and has been a kind of national advocate for the need for this. And she kind of helped recruit who the other advocates were, of understanding other survivors who wanted to be involved to help other families through this journey of survivorship. Once the advocates were identified, they went through the police department victim services training. So any victim services employee with the city goes through a set training through the victims advocates unit, and that was the same for these three advocates. They've since hired a fourth because Deandra has stepped out. They are compensated through the grant as contract employees with the city. So they are paid hourly in the same way that a civilian employee would be paid. And from within the police department, they are just considered contract employees. And sustainability is definitely a piece of it, one from keeping the program within the department. So again, it is funded through another grant for another 3 years. The hope is to bring it into the police department budget. But I think from a sustainability standpoint, from kind of the health of the advocates, that we're going to need to get some sort of technology-based outreach or way that the advocates don't have to do the outreach on a daily basis for their own longevity in this type of work. I think I answered that full question.
Yes,
Okay.
really interesting. I in some ways am interested if you all had looked at models for example, overdose outreach. A lot of police departments have programs where they go back to a house where they treated an overdose the day after the event and maintain contact and make referrals. Have you looked at those models for any possible transfer of knowledge or?
We have not specifically to overdose, but that would be a great concept. I know that there were discussions about doing over the phone outreach or going to the house of the survivor, and it was determined to do it via phone from a safety standpoint to
Mhm.
start. Yeah, but those are
Yeah,
great suggestions.
absolutely. Well, those are all the questions we have. So I want to thank you for a really interesting talk. I think you've given us a lot to think about, and we appreciate you. So I see your contact info is there. Can
Yeah,
people send
would be happy to.
correspondence?
Yeah,
Okay.
happy to take emails of other questions, and thank you very much for having me. I apologize that my PowerPoint paused and gave out during this presentation.
It all worked out in the end, as it's
It-
wont to do. So
yes.
thanks again, Dr. McGee. We appreciate you.
Thank you very much.